So this is the podcast version of our bioethics grand rounds on advanced care planning. And in this session, we'll discuss the concept of an advanced healthcare directive, as well as the concept of surrogate decision making and power of attorney. So we'll talk a little bit today about what is an advanced directive and the other names that advanced directives go by, also power of attorney and their various names. Issues at end of life that come into play when patients have implants and they haven't done advanced care planning, and then also give you some sources to help you with locating advanced care planning documents. So what is advanced care planning? It's planning for your future health care. It's thinking about the types of health care that you would want and not want if you were in a situation of severe illness like a permanent coma or a terminal diagnosis, and you're going to die in a relatively short span of time. What types of healthcare interventions would you be open to receiving, and what kinds would you not want to have? And the list could be long, the list could be short, but it's the fact that you think about it now when you're healthy to plan for that unfortunate future possibility. It also includes the concept of choosing a surrogate decision maker to make decisions that align with your values. Because when you're sick like that, you won't have the capacity to make those decisions and to speak them out and communicate them to your medical team. So by choosing a surrogate, they'll be able to communicate your values and wishes for you. Now, advanced directives have many names depending upon the jurisdiction that you reside in. So they can be called a living will, refusal of treatment certificate, certainly advanced directive, a statement of choices, and on and on. But they're all referring to the same thing. It's a document, a written document that states what your values and preferences are about healthcare in the future when you lose the capacity to make those decisions for yourself. Now, who should, in fact, should do healthcare planning for their future? Actually, adults, any adult with decision-making capacity can do advanced care planning. The worst thing to do is to wait until you're sick, try to pull out one of these documents and work on it. It's not a good idea. It's generally a very stressful time, an anxious time, a time where potentially you're under pressure in terms of needing to make a decision. Um, so it's really much better to do it at a time when you're not sick, not pressured, where you've got ample time to sit down in a quiet area, think about your life, your values, your past, your future, and where you're going. That's the great time to do advanced care planning. In terms of nominating someone to be your surrogate or power of attorney, again, depending upon your jurisdiction, there'll be different names for those people, but they all are the same thing, whether you call it an enduring power of attorney, a substitute decision maker, an agent. The function is the same. They're speaking on your behalf. But the most important thing is that you proactively appoint someone to be a surrogate who will actually honor your values. That's their duty. So don't pick somebody who has uh, feelings and preferences and value set that is diametrically opposed to you. That's only going to make for very difficult situations in the future. And you also want to appoint one surrogate and one alternate. The reason being is there are times where phone calls are made to the surrogate and they can't be reached. They're unavailable, they're out of town, sometimes they're deceased, or they're not interested any longer in being the surrogate. So having the alternate available through the documentation is great. So always good to appoint one and an alternate. It's a really bad idea to appoint joint surrogates, so two people on line one as the quote unquote primary surrogate. And I've seen people do this before, and what happens is joint surrogates often can't agree. They fight and argue, and what you just have are situations of conflict in the setting of already a very tense and you know, unfortunate situation of a tragic health matter. So you don't want to add to that. Make it very clear who your primary and your alternate is. Now, some patients get a little nervous when they think about the idea of healthcare planning and appointing a power of attorney because they worry that this person, this surrogate, may also have the ability to get into their checkbooks and do things with their stock and property and such. And it's really important to make it clear that the durable power of attorney or enduring power of attorney for healthcare is only, in fact, for healthcare. Financial matters and financial living wills and all this and that are totally separate. So you want to make that clear with your patients so that they don't get confused and decide not to do one of these documents out of misinformation. Now, patients may ask you, yeah, well, why should I do this? Why should I fill out these forms? They're long. I don't want to think about these questions, et cetera, et cetera. Well, it's a really good idea to be proactive in thinking about your future. Um, Medical teams will know what you want as well as what you don't want, and so will your family. So these are great reasons to do advanced care planning. There's no, gee, I'm not sure, I wonder what. Um, Things are in writing. And this way also patients aren't overtreated or undertreated, and both of those things can be very problematic. Now, in terms of advanced care planning and limitation of treatment, uh, there are all sorts of interventions that can be considered. Things like dialysis, ventilation, intubation, feeding tubes, antibiotics, blood transfusions, CPR, chemotherapy, the list goes on and on. So, as a patient or as a clinician working with the patient and discussing advanced care planning, these are the type of things that should be put on the table and thought about in terms of what might be considered and what would be considered as not wanted in terms of a situation of a terminal illness. So these are questions that you will probably hear from patients, and you want to have answers to them. So, does the medical team have to honor a healthcare advance directive? And the answer is yes. If the advance directive appears to be a valid document, which in general they are, if the signatures are present, um, and the only thing that you don't have to honor are things that are requested, which are actually illegal in your jurisdiction. So if in your jurisdiction euthanasia is illegal, but the advance directive is saying, I want to have euthanasia if I have a terminal illness, you don't have to honor that. And actually, you should not honor that. Next question, does the family have to honor a healthcare advance directive? Yes, they do. This is because advance directives are actually considered legal documents. So, but separate from that, they actually have an ethical duty to honor an advance directive, and that's really important. That's the duty of a surrogate, is to honor the wishes of the patient. Next question, can the patient change their mind and write a new advance directive? The answer to that is yes. So as long as the patient retains decision-making capacity, they can change their mind. They can write a whole new advance directive or change different pieces of it. That's also okay. And lastly there, does an advance directive have to also include appointing a surrogate decision maker? The answer to that is no, it doesn't have to. Some people choose to only write down what their values and wishes are about treatment, and they choose not to appoint a surrogate. Um, but if you are a clinician, I would counsel your patients to think strongly about that omission, because it does leave a gap there. It's really important to have a surrogate decision maker for when questions arise that maybe aren't crystal clear in the document or weren't covered in the document. Really having both components addressed in advanced care planning is really valuable. What if the surrogate who is appointed as decision maker does not want to do the job? Well, that's fine. While they may have been appointed on this official document, they don't have to be the surrogate. They can decide not to. They can back out. They are not legally held to do it. So that's okay. Um, and you would then go to the alternate who's listed on the document. That's why it's so important to have an alternate. Next question. What if the surrogate who is appointed as decision maker is not following patient wishes as stated in the advance directive? This is actually a common reason for calling a clinical ethics consultation. And there are surrogates who, because of their own personal values, sometimes do not want to follow a patient's advance directive. So the ethicist will meet with the family and the surrogate and discuss with them the fact that, well, this is a legal document, you are appointed as a surrogate, and your duty is to honor the document. If you can't, then you can't function as the surrogate. And so it's basically, you have an education session with the surrogate to inform them what their duty is. It's not optional. uh, the duty is to make decisions that are in accordance with patient wishes. If they can't do that, then they can't function as a surrogate. It's crystal clear. Next question, does an advance directive expire? Well, in general, advance directives do not expire. Um, there are some advance directives, like those for mental health, depending upon the jurisdiction where you live. Those may have indeed expiration dates, so that's a different matter. But generally, in the vast majority of places, standard healthcare advance directives do not expire. Next question, do doctors honor advance directives from patients in other countries or states? And the answer is yes. It should not matter, especially, for example, if you live in an area or your hospital is in an area where there are lots of tourists. So that could be LA, it could be New York, it could be Gold Coast, Australia, um, or it could be Paris. There's a good chance you're going to have lots of tourists coming in, and there's a good chance that you're going to have tourists entering your hospital, and they may in fact have advance directives. So yes, you do honor those, but again, if there is something in that person's advance directive that conflicts with the laws that are in effect in your country at the time, then you just don't honor those particular elements of the advance directive. And the example that I gave before, like euthanasia, you would honor euthanasia in the countries where euthanasia is legal and not honor it in the countries where it's illegal. All right, are patients required to write an advance directive? The answer to that is no. It is purely optional. Um, in some jurisdictions, hospitals are actually required to ask patients if they have one. And if they do, then they try to get a copy of that document from the patient so that it goes into the chart. Certainly, patients can refuse to provide them, and I've been in situations like that before. Or actually, the surrogates have refused to provide them. That's another very complicated situation. But overall, the point of this is that no, patients are not required to write advance directives, but it's really a good idea for them to do so. Next question. Must attorneys, lawyers, solicitors be involved in writing advance directives? The answer is no, but I've heard many, many horror stories about patients getting involved with these services, paying literally several thousands of dollars for a simple advance directive when it's absolutely completely unnecessary for these folks to be involved. So it's a bit predatory, and patients actually should be warned so that they're not taken advantage of. It's one thing if you want to get an attorney to help you write a financial living will, last will and testament. That's very different and very appropriate. It's another matter to have them involved in a healthcare advance directive. Question, does the doctor write the advance directive? No, doctors do not write advance directives. Um, Doctors write things like do not resuscitate orders, not for resuscitation orders, things like that. But they themselves do not write advance directives. Now, in Australia, interestingly, oddly, doctors have to sign a patient's advance directive. And what that means is that the doctor is aware that the patient does, in fact, have decision making capacity. Um, but it doesn't mean that the doctor is corroborating or, agrees with the content. It is a bit of a tricky area though, because I personally believe that this signature requirement actually discourages people in Australia from pursuing advanced directives because it's one extra labor step in the process, and they may fear a bit of paternalism from doctors trying to steer them one way or another in completing their advance directive instead of having it be a personal and private matter. So it's something that Australia, I think, needs to reconsider. I also think it's one of the reasons why we have such a very, very low rate of advance directives in the country. What else do doctors do? Well, patients will often approach their doctors for advice about their advance directive, and I think that's a great idea. And so the job of clinicians, as well as anybody else in the consultation process, whether that's the clinical ethicist or a social worker or a nurse, whenever you're discussing advanced care planning with a patient, you need to use lay terms so that they understand what's going on, because a lot of these technologies are difficult to understand. The words are complex, so you need to help the patient understand. Also, some people do have a fear that advanced care planning means people automatically go directly into hospice. They're going to suffer. They're going to be in pain. Their wishes are going to be ignored, et cetera, et cetera. And this is a great time for everybody in healthcare to be counseling patients that those are myths, that's not true. And also, there is this concept of palliative care, and inform patients about what the palliative care team does for patients as well as families. So there actually is a big role for clinicians in educating patients about advanced directives, but I think it should be done in a way that's not paternalistic. Question, is a special form required to write an advanced directive? Well, you can answer that in a couple ways. Firstly, lots of places have come up with templates based on the legal codes that are in their specific area. So if you were to do a Google search on advanced directive, you would find hundreds of templates for advanced directives. And basically, patients can use whatever they want. Again, you just want to keep within the guidelines of the law, uh, so that your form can be honored. And most specifically, that would apply to things like signatures on your document. You want to be sure you have the right signatures that may be required so that your form can be considered valid. And that's going to vary depending upon which state, country, territory that you live in. I've got two sources for you here. I have an advanced directive template on my website, which is asktheethicist.com. And for those of you that are in Queensland, Australia, the government also has a template here at this web link. I've got a picture of it here. So this is the advanced directive form for the state of Queensland and Australia. I've got to tell you, though, the problem with it is it's 24 pages long. And I think that the average patient who goes to this website and aims to use this form is probably going to get discouraged and not use it, because it's just pretty labor intensive, pretty laborious. Reading through 24 pages is I think a bit much, but that's what That's what's on the books right now. So that's the current template from the government of Queensland. But again, like I said, there's templates all over the internet, and patients can use whatever they want. Now, what if your patient has no advance directive? So if your patient has no decisional capacity, no advance directive, then what you do is you make medical decisions in what we call the best interest format. So, what would be appropriate in terms of the standard of care in light of the burdens and the benefits, and also considering the concept of futility and quality of life. What would the average patient in this situation likely want? If your patient has no appointed power of attorney, um, often there is an order of priority deemed by law. But again, some states and territories, countries don't have that. So you're going to have to check on that depending upon where you're practicing medicine. And if there's no next of kin, no friends, nobody at all, often those cases are referred to clinical ethics consultation or a guardian's office. It just depends upon um, what the situation is, the time spans, things like that. Now, there are some very interesting ethical issues that arise with implants in patients. And interestingly, doctors actually often fail to think about this and fail to discuss this with patients. So we've got a lot of implants being implanted, but it seems to just the discussion seems to just end there, and surgeons and physicians aren't having end of life discussions with patients to sort of tell them the extra things that are involved with an implant. And this discussion actually needs to happen before implant during the consent process. So it's sort of like when you buy a car. You learn all about the car that you're buying and the maintenance that it requires, and potentially the costs of parts and repairs and service and all this and that. Well, an implant really needs to be handled in the same way, but sadly, in general, they're not. They tend to be implanted, and that's it. But that creates many downstream dilemmas. Now, in the setting of end of life, advanced directives can be really important for people who have implants, because implants often need to be turned off when patients go on comfort care at the end of life. There's also situations sometimes where the need arises for potentially a battery replacement or even other parts of their device. And so patients need to have thought about this in advance. There are also issues with the death of a patient and what to do when a patient has an implant. Um, Obviously, everybody's aware that you don't cremate bodies that have implants, but also in some jurisdictions, they don't want bodies to be buried with implants either. Because of the degradation over time of the implant and the potential harm to the environment. So again, this is the reason why it's really important to think about all of this up front and to document values and preferences in the advance directive. Now, when we talk about implants, we're talking about all sorts of things. Most commonly, we're going to be thinking about the pacemaker and defibrillator. But there's a lot of people out there who have other sorts of implants, like deep brain stimulators for conditions like migraine, epilepsy, mental health, um, Parkinson's, etc. Gastric stimulators that we have, also ventricular assist devices, and pain pumps as well. So this is just a snapshot of what we would be thinking about in terms of implants and the end of life. So in terms of that consent discussion, doctors need to be telling patients if their particular implant is considered a form of life support. And certainly defibrillators, pacemakers, and ventricular assist devices are considered life support. Um, Doctors also need to inform patients if their implant requires any sort of maintenance, over time. So parts and service like batteries. And then this needs to be reflected on in terms of writing that advance directive. This is a sample here that comes from the advance directive that I have on my website. And you can see here that patients would just check what type of implant they have. And then there is further questions there pertaining to removal of the device after death, return of the device, analysis of the device, etc., etc. But to the best of my knowledge, this is the only advanced directive template that I'm aware of that includes the concept of implants. So another key point when you're having these discussions is that turning off an implant during end-of-life care is not euthanasia, and it's not killing a patient. And patients and families need to understand this. And fundamentally, the reason why it's not euthanasia is that the patient already has an underlying disease. So whether that is heart disease or whatever else that we're talking about, that's what actually continues on. It progresses, it gets worse, and the patient dies naturally from their disease. It has nothing to do with the device being turned off. The patient already has a disease, which in fact and ends up killing them. So that's how you need to frame those discussions. Now, failure to turn off an implant, especially we're talking about a defibrillator now, can be really a bad thing for patients and their families at the end of life. And I have received several ethics consultations because of doctors were refusing to write DNR orders and refusing to turn off these implants at the end of life. So patients were actively dying and they would get near death and then the defibrillator would fire. And essentially the patient would be brought back, and this would happen over and over and over, and both the patient and the family were just being tormented. And we can't have this happening. These devices do need to be turned off, and that needs to be part of the do not resuscitate order. This here is an article that describes that. So if you think it's not true, if you think that it doesn't happen, this article here will tell you all about it. Also, in support of this concept, I have an article here that talks about how you use advanced directives and DNR orders in conjunction with turning off these devices. So it's part and parcel. Here's another article that I was part of. So I was on the research team with the Mayo Clinic, and we did a study about deactivating or turning off these devices in patients who were terminally ill. And indeed, we found any physicians that we surveyed were very uncomfortable with turning these devices off. They didn't like the idea, and often they would ask the device manufacturer to come in and get involved in that process. And I think that's really unfortunate. That's not the job of the device manufacturer. Patients, shouldn't be subjected to that. Doctors need to be responsible for the devices that they put in, and they need to be having these discussions with patients and families very early on. And if they're not comfortable with that, they need to get another physician involved to have these discussions, but they can't offload it onto someone else who's not a clinician. And if there's a real problem, definitely you need to call a clinical ethicist. So if you've got the form now, the patient has written an advance directive, they've signed it, now what do you do? So the last step is one of the most important steps. So the form is valuable, but unlike a piece of jewelry or stocks and bonds, you don't want to put it in a bank safe or deposit box. And the reason why is nobody's going to be able to get it, or they certainly won't be able to get it in a timely fashion. So the physician should have one. there should be a copy in the electronic medical record, or if your hospital's still doing paper charts, then put a copy in the paper chart. All the surrogates, primary and alternates, they should have a copy, and the patient themselves should have a copy kept in their purse, briefcase, backpack, whatever they use as their regular accessory that they keep their important stuff with on a regular basis. Um, because you just never know. You could even keep a copy in the glove box of your car, for example. But the worst place to put it is in the safe deposit box because nobody can get to it. So lastly, the take-home message is encourage your patients to draft an advance directive and appoint a surrogate. And I encourage you, especially if you're a healthcare worker, to draft one for yourself. Thanks. And here's some helpful resources for you on the topic of both healthcare living wills as well as surrogate decision making.